the medical field and you want to talk shit about your patients, especially your young, healthy-looking female patients, please make sure that you're educated on dysautonomia first.
Why would people with dysautonomia get dismissed as faking their symptoms?
My patients with dysautonomia, let's talk about it. This is for all my inserters. If you come across a patient diagnosed with dysautonomia, you need to collaborate or should be collaborating with them. If they're unconscious or dead, I don't care. But if they're conscious and you're doing these procedures for long-term therapy, just know that the lidocaine and bupivacaine, it does not work for them very well. The onset of efficacy is very long, the duration of efficacy is very short, and the level of efficacy is very low. And so if they say they have dysautonomia, I immediately, if they don't have allergies, I'll go ahead and just mix lido and bupivacaine 50-50 and then inject that. That way we can start as soon as possible. Sometimes it'll take even a whole hour and a half before that medication starts kicking in. It sucks, I know. However, if the patient's not dead or dying and you rush past that, why did you even try to give them a local anyways? Just make them suffer. Why do you care if you're not even gonna wait for it to work? Just know that it takes much longer. Now, here's another issue. If you want to use epi, you're like, hey, I got a great cocktail actually, I'm gonna just add epi to lido. Be very careful if you're gonna add epi, and you better have them on a cardiac monitor because they are very sensitive to cardiac medications, and you may prolong tachycardia for them, and you don't know, and really nobody knows, the proper dose for them to not induce this significant tachycardia, even with the sub-Q injection. I know, it's crazy. But just know, I don't do it for my dysautonomia patients because I know that population. You do what you want to do, but my recommendation is be very careful with that. Now, generally for my dysautonomia patients, they have these weird sensitivities and allergies to polyurethane, acrylic, cyanoacrylate. And so I highly recommend you get allergy tested if you have some time. If not, do a skin test to make sure and let your provider know you're doing it. However, they do have these issues. When we put on that acrylic allergen on their skin from the dressing that comes in the kit, we're gonna make that site rashy. And what happens when we get rashy insertion site? It starts to get infected. And what happens if it gets infected? You have to pull out that beautiful line you just placed. For this next part, I am a consultant for Covalon, so take what I say and what you hear from me with extreme skepticism because I do have my biases. So please vet the information for yourself before you make any changes to your patient care. For dysautonomia patients, because I've had so many issues with them with these acrylic dressings, I use Covalon IV Clear. If they're allergic to CHG or silver, I go straight to Cova Clear, which is silicone only. You want to use silicone-based dressings. I believe Mepilex is also silicone, but I'm not sure if they're rated for IV insertion sites. It doesn't matter. It's up to you if you want to use it off-label. However, those are the dressings that I go to for these patients so that they don't react and have that itchiness.